at you. Man, I can't get that relaxed. How do you do this? You're like amazing. All right, I'm chilling.
Ryan Stanton here with ACEP Frontline, joined again today by Dr. Mark Rosenberg, a good friend of the podcast from St. Joseph Health System up in New Jersey, who, typically we're talking and we've associated with him with the Alto programs and opioid managements and some of the success that they've had, but he's also very interested in geriatric emergency medicine. Actually, we just recently talked to Dr. Weiss, and I believe one of your facilities was one of the first level 1 geriatric emergency departments, and giving a talk at Leadership and Advocacy Conference in Washington, D.C. about end-of-life issues, geriatric care, and we've talked to, I talked to Dr. Alex Sirides at SMACS twice now, once in Ireland and once in Germany, about their approach to end-of-life care and palliative care and those sorts of things in New Zealand, and many times they're amazed at what we do here in the United States and the amount of money and resources we contribute to end-of-life related issues and even fetal care. It's really something that's pretty unique for much of the world, what we do here in the United States. And it's going to be a big and very important issue because we have this aging baby boomer population. We're all on the same road. Eventually we will be on this earth for the last day. And it's something we as emergency physicians, we in the emergency department, can truly start to invest in and look into and consider and really drive the conversation. So as I've already driven down the road on this conversation a fair amount, Dr. Rosenberg, give us a little background on this and the importance of considerations with this population aging in America.
Well, thanks for having me here today. This is a great opportunity for me to really talk about something that is one of my major passions in emergency medicine. If you look at the numbers, and you ask people, how do you want to die? Most people are going to tell you they want to die in the middle of the night. They want to die in their sleep, or they want to have a sudden MI. And if I ask people how many here want to die, if this is a big classroom, how many here want to die from cancer? You don't really get many people who raise their hand. How many want to die from a organ failure like heart failure? And you don't get a lot of people to raise their hand. And how many want to die from dementia or the dwindles? And nobody raises their hand. But if you look at the numbers, only 6.4% of the population in North America, including Canada, will die from a sudden death episode. The majority of people, pretty much 1/3, 1/3, and 1/3, will die from either a cancer trajectory, organ failure trajectory, or the dwindles. And each one of those areas can benefit by palliative care. The studies show that people who get palliative care actually live longer, have better quality of life than those who get aggressive treatment.
Interestingly, you say that because I think that's just the opposite perception within the general public and even potentially within healthcare, that, once we get in palliative care, that's it. We're throwing in the towel and you're done. And, we're going to put you in the palliative care. We're giving up on you. We won't see you anymore. And 3 days later, you die alone somewhere. And that's just simply not the case. And I hear that more and more about the numbers that are showing that the outcomes are actually better. The satisfaction is higher. The life is longer. The time with the family is improved. And yet, what our health system, our medical system in the United States tends to focus on is beating people mercilessly as they head towards the tunnel, to where the last days, even if we can buy a little time, we may not buy quality, can be miserable for these patients. So go into a little bit of what we get wrong in this country when it comes to the way we treat palliative care.
Let me first tell you about what our quality of death score is, because that will be the striking number to put this into perspective. And then I'll get into what we do wrong, because I think the first part's really important. There's an organization called the Lean Foundation that does quality of death scores across the entire globe, looking at every single country in the world. And the United States usually comes in the top 12. In the past year, and I think it was 2015 that they last did their study, the United States was 9th. But when we break down why the United States was 9th, is where the fascinating small print comes in. The United States actually ranks in the 2026 range if we take out the access to opioids. This is almost funny, the fact that we have so much access to opioids puts us up higher in the quality of death ranking than countries who have restricted opioid access. So we're in the 20 range, and add in our easy access to opioids, we end up overall in around 9 in the top 100 countries. The worst is Iraq and Iran, where they rank 100 because there is zero access to opioids in those countries. So in spite of our opioid epidemic, that's where we are. The reason we're not number 1, which is the UK, and number 2 is Scandinavia, the reason we're not is because we have very little public support of hospice and palliative care. In the UK, and this goes back to your original question, what do we do wrong? In the UK, when you go into hospice, you and your family get tremendous support from the government and from society, so you have nothing more to worry about. Financially, all your care is taken care of. Your social and spiritual needs are also taken care of. And contrast that to the US, where we look at hospice, unfortunately, as your last days on earth. You will be in hospice, and everybody thinks that's a bad thing. In the UK, they rejoice about it. In the US, we really think it's giving in or giving up.
Do you think, how much of this do you think has to do with our fear of death in the United States?
Look, we're all going to die, and somehow we all get through it. And it's absolutely fascinating to me how we can get through some of this, how we can get through dying. But we as a country, we as a people, are very afraid of dying because we are afraid to even talk about it. Actually, if we look at the Navajo population, they are not even allowed to talk about death because they believe if you talk about death, you allow the spirit of death to actually enter your body and you will die sooner. And it's almost like us, all the Americans almost feel that way. They're afraid to talk about death and dying, but it's going to happen to all of us. And if we can have a conversation with our family member about death and dying, we will actually have a better result. Let me give you an example. Family came to me, and the husband was dying. He had myelofibrosis, and it was not curable, and he was going to die. And they came to me and they said, what should we do? And there is a form called a personal self-assessment form that any one of us can fill out. And really it says, what do you want done if you're 100%? Ryan, I feel pretty good today. All my body systems are working. I don't have any pain, and I woke up this morning, I exercised. I feel great. If I should have a cardiac arrest now, I want CPR done because I'd like to survive this. I'm feeling pretty good. But how about if I was at 70%? How about if I really had difficulty doing my activities for work, that I was bedridden a lot of the time, or I just couldn't wake up? I was able to feed myself, but with some difficulty. I may change my mind and say, if I had a cardiac arrest now, just let me go. If I was 30%, and this is all on the form so you can see it for yourself, if I was at 30%, where I was at bed all the time, I couldn't take care of myself, I maybe had some tubes to help feed me, I would welcome natural death. So this personal self-assessment form really allows all of us to take an inventory of how we feel about dying, and more importantly, have that conversation with our spouse or even our kids. What do they think about it? Don't be afraid of it. Talk about it, because it's going to happen to each and every one of us.
I think one of the keys is getting your family involved, because that is really one of the most frustrating things that I deal with, or that I feel, and I think many of us deal with, is somebody who has laid out their advanced directives, their wishes, and then the family comes back on them. They get in there. So, I've got a patient that's upper 90s, metastatic cancer, probably septic, cardiac arrest, and family is like, well, the person would want to live, so do everything. And you know what that means is, the intubation and the cardiac arrest and the CPR on a 96-year-old. You can imagine how that goes. And it's barbaric, and I feel like it's almost, there's physicians out there that feel that it's unethical to do a lot of that stuff to those patients. But, then there's the potential that the family could come back and say, well, they woulda, coulda, shoulda lived. And, we don't have a system to where the patient's wishes are steadfast. We don't have one that says, I've signed my form that says I'm a DNR, and nobody can take that away from me.
So we all run into this problem, right? Every day in the emergency department, you run into that type of situation where you get somebody who has advanced disease, and they come in and they're extremists, and you have to decide to resuscitate them or not, particularly if it's cardiac arrest or respiratory arrest. And sometimes you question, should I do this or shouldn't I? Sometimes you run out to the family and says, does your mom want everything done or nothing done? And none of those work. That is not the right way of doing it. When you intubate somebody, you can extubate them. Or you can use a temporizing situation like an LMA, where you actually have to put in a definitive airway in a period of time afterwards. So what I do, somebody comes in and they're really an extremist and they're cardiac arrest, and I don't have defined explanation of what they want, I go ahead and I resuscitate them. Not so much CPR, but I intubate, I do what's needed. Then I arrange a family meeting. Now, I'm a palliative medicine physician who happens to work in the emergency department. I could see that family the next day, but you can also arrange for such a thing. And when you meet with the family, you have the opportunity to sit down with them and say, tell me about your dad. What is he like? And the family here's the scenario. Dad comes in with an unsurvivable intracranial hemorrhage. You know that he can't survive. You've seen this before. And if he does survive, he's not going to be able to really function well. So you say to the family, tell me about your dad. What is he like? And they may say, he loves two things: play in the garden with his grandchildren and take care of the garden. That's his love. And you can definitively say to the family, based on this bleed, he will never do that again. And you may get an answer right away from the family saying, well, he wouldn't want to live then. And all of a sudden, your job becomes easier. So as an emergency physician, your job is go ahead and intubate. Find out what the family wants or what the patient wanted. And then go ahead and make those reversals if that's appropriate or necessary. If you ask them, what does dad want, everything or nothing, the answer is going to be everything. Mm-hmm. And then you're going to put yourself into a box and the family into a box. Just do what you need to do medically, and then have the conversation, and then reverse what you had done if that's necessary. If we look at choosing wisely criteria that ACEP put together, I think it was in 2013, and what they said is do not delay referral to palliative and hospice care for those patients who could benefit. The biggest problem here is, how do you identify those patients who could benefit? And it's actually very, very simple. There's a question I call the surprise question. And if you see a patient who is so extremely ill with advanced disease that you would not be surprised they would die on this admission, then that's the patient you need a palliative consult on. In my hospital, everybody's empowered to call a palliative consult. if they believe the patient will not die, will die this admission. Even the paramedics and the EMTs, when they bring in a patient, they can say this patient may die this admission, they warrant a palliative consult. And then we go ahead and we go through our pathway to get that information to not only the emergency physician, but also we call in a palliative consult for those patients.
How do we reconcile, you've talked about some of that with a DNR paperwork sitting right in front of you and family mixed both ways of yes versus no versus bickering back and forth. We've got continuous situation here. You've got that, as I say, that paperwork, legal paperwork right in front of you. Where do we go from there? Because I know a lot of our emergency physicians are going to deal with that situation as well.
I think it matters what form it is. So if it is a DNR that's from a nursing home, you really don't know how valid that is. That needs to be validated by talking to the family. You're not sure of the process. It's not signed by a physician typically, or maybe it is, but the physician's not on staff. So it creates a lot of questions. However, a PULSE form or a MOST form that's available in many states, those are considered legally physician orders that are transferable wherever the person goes. That is legally binding, at least in my state it is. And those individuals, if somebody comes in with a PULSE form in my hospital, we will abide by that even with family, if the family doesn't agree. If they come in with a DNR, it's much harder because you need to validate whether that's a true DNR, what that means. Is there a physician connected to that? When did the family last hear about this? So I always, a DNR or advanced directive, I usually go ahead and stabilize the patient the best I can, then figure out things afterwards. Once a patient's dead and gone, they're dead and gone. There's no chance to do what their wishes were.
That's one of the drawbacks, I believe, to the EMR system is a lot of times that they've got something in there. And I've actually had families that have been very angry afterwards because of resuscitation, at least one. Because of resuscitation, they say, well, it's in your paperwork, it was in your medical record, and it's like, I don't have access to my medical record when I'm in here resuscitating your family member. That stuff that needed to come with them or need to be presented is right there because I'm not looking at the chart until afterwards. Being able to dig back into the charts, EMRs don't necessarily, or EHRs, whichever you want to say, are not necessarily made for that easy access to advanced directives, living will, that sort of thing. And, in ours it says prior. So they've got one somewhere. You just have to find it because it was prior. And that can be incredibly difficult. What can we do better? What are the steps and things we can do better in the emergency department with regard to, so then we don't have a system is set up and streamlined as what you have. How do we, what are some things that our emergency departments can do to make those next steps to be prepared and ready to take care of the palliative and end-of-life issues?
So I think the first is to do an inventory of your hospital and surrounding community. What palliative and support services do you have within the hospital? Do you have a palliative service? Do you have a hospice service that's affiliated with the hospital? Does your community have hospice services? Think about clergy and what type of support you have from there, and make that inventory something that's accessible to you when you would need it. Remember, people who come in actively dying have emergent suffering. And our job as an emergency physician, first and foremost, is to address their suffering, whether it's physical, psychological, spiritual. We need to address all those. So once you have a patient who's now actively dying or is actually a cardiac arrest and now be resuscitated, but somebody who's really unlikely to survive this, use the resources that you identified to provide the patient with that referral that ACEP suggests in its choosing wisely criteria. So let me give you an example. A patient comes in with a a malignant pleural effusion from a pelvic cancer, advanced disease above and below the diaphragm, stage 4, and they now say to you, and every time they get a tube put in their chest, and they say, I never want to come in here again. And you say, okay, I hear you. Let me get you some palliative support. And you call the palliative services that you already identified. Let's say that patient now comes in as an extremist and needs to be intubated or something like that. You also now go ahead and intubate them, but the next step is to identify the palliative services that would best help this patient without delay, because you don't want them to linger in the unit for the next 2 weeks without having any opportunity to talk to somebody about their goals, their wishes, to palliate their situation, and possibly get them home with a tube that you can put in even in the emergency department.
What are some of the, I mean, I guess we could have mentioned it earlier, what are some of the benefits of, you mentioned that that they live longer, do actually better with palliative and hospice type care. What are the things that we add or the resources they have that cause or result in better outcomes overall with a patient?
So I think it's two things. Number one, we could do this as an emergency physician, but what does hospice do? And hospice are the leading experts on the planet in dealing with symptom management. Not so much hospice, but the palliative physician. They can deal with shortness of breath. They can deal with all different problems that you get from advanced disease, whether it's cancer or even dementia and otherwise. They are the experts. So that way, the patient does not have as much suffering, and they're much more comfortable going through their life with better quality of life. The other thing that hospice does is it unburdens you as a family member and you as a patient. It takes away a lot of the concerns you have. It gives you the comfort. They bring in durable goods, so possibly you can get a bed on your ground floor. They supply you with a care team that's actually going to take care of you, so you don't have worries day to day about your medication, about your pain, about your constipation, about whatever it is that is limiting you from living your life and living your death. These are the best opportunity to provide better care at the end of life using hospice and palliative services. So as an emergency physician, become very good knowing how to manage symptoms that patients come in who have these advanced illnesses. Number two, know how to refer them appropriately to palliative and hospice services. And number three, know how to talk to them. But that brings about a problem. I think the question is why can't emergency physicians do this? If I may, let me just talk about that for a minute. When you're an emergency physician and you're seeing a patient who's having chest pain, and you have two other patients that you need to see, one who's short of breath and maybe even a pediatric patient who's having stridor, you're running from case to case to case. Add to that somebody with advanced disease who's short of breath. You don't have time to sit and talk to them about their goals and their wishes, not when you're in the middle of a shift. You need to create a structure where you can call down hospice to possibly talk to them, where you can bring in the social worker or the care manager to talk to them. The bottom line is don't put the burden on the emergency physician to do all the aspects of care that's needed. All you need to do as an emergency physician is identify the fact that this patient could benefit from this type of service, and then call them in as a consult to provide that service if it's available in your hospital.
I'm glad you touched on the aspects of the challenges from an emergency physician standpoint in terms of timing in the rest of your job. It's very difficult. I mean, a lot of these things we discuss do involve sitting down, more time with the patient and family, longer discussions, more work. And that is one of the challenges that we deal with in medicine, is that we're pulled in so many directions. So you definitely need to have those resources available in the emergency department as best we can. And I think we're going to see growth of this significantly as we move along and we start looking at value-based medicine and care, and how can we better address the current needs and outcomes and disposition plans of our patients. It's just been a few years that we've been at a pretty fair amount of social work and case management in the emergency department, and I think we're going to see more and more of that, because it needs to happen before they get admitted. Can we prevent admissions by getting those things arranged? And I think that's one of the greatest gifts and things that are value added of palliative care, and especially hospice, is that availability of resources, people that can make things happen, the things they need at home, whether it's a hospital bed, whether it's some railings, whether it's their medications, whatever it may be, in order to help keep them out of the hospital. We know so many of our visits to the emergency department are absolutely related to not having something you need. So, that's pretty amazing, and things that they add. So, great conversation. Where do you see us going?
Well, I think we first have to realize that if you're older, if you're on Medicare, you have, as part of your Medicare policy or agreement, that you have hospice and palliative services available to you as a benefit. Many people die and suffer alone without using their benefit. So I think as emergency physicians become more aware of hospice and palliative services and how to implement many of those skill sets in their emergency department, I just think that we're going to be better caregivers to understand not only how to take care of the cases that we see every day, but to take care of those difficult patients who really need us most, and that's those who are end of life.
Consistently, I hear folks say that their only regret about hospice and palliative care is that they didn't get involved for their family member earlier. I don't know if you know off the top of your head what the average hospice involvement is, but I know that most people say they wish they had known about it earlier. My grandmother, for instance, we wish we had had them involved earlier as opposed to the last few days of her life, because of those resources they can bring, and taking a lot of the stress and impact off of our families.
The Medicare guidelines are that anybody who's expected to die within 6 months is eligible for hospice services. And I don't know the exact number, and you asked a very good question, but most people in the United States invoke their hospice privilege at the very end, where there's just days left. But it's important to realize that hospice is one of these privileges, benefits, that you can enroll in and disenroll in anytime you want. What I recommend to my patients is call hospice, interview them, even try them out for a couple days. If you like it, continue using it. If not, stop using it. There's no harm in trying hospice and seeing if it's right for you.
Talking with, you seem to be coming around for a lot of our podcasts, and I appreciate all of the knowledge and things that you guys are doing up there at St. Joseph Hospital and centers up there in New Jersey. So Dr. Rosenberg, how can folks, here it is, I've got in 2004, I just found it. In 2004, the average stay was 57 days, the median was 22 days, and actually 33% of hospice patients admitted in 2004 died within 7 days of admission to hospice care. And I thought I had heard somewhere that 2 weeks was kind of how long, but I know many of the family members we see, it's much shorter than that. And so it's something that we need to consider in emergency medicine as more and more of this role as the hub of the hub of the medical system grows. This is something that's going to be added to our plate in order to provide the best care and resources to our patients and their families. Dr. Rosenberg, how can folks get in touch with you if they have any more questions about this?
Twitter at Dr. M. Rosen, and you can reach me also at M. Rosenberg, Rosenberg, at ACEP.org.
Fantastic. Once again, thank you so much. As for me, youreverydaymedicine@gmail.com, youreverydaymedicine@gmail.com, at everydaymed on Twitter. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.